We are here today at the SEEK National Workers' Comp and Occupational Medicine Conference with Melody Rasmore, a certified family nurse practitioner and occupational health nurse. Dr. Rasmore, what are some of the biggest mistakes you have seen at musculoskeletal neurological assessments?
Well, in my practice, I teach at Washington State University, and I teach a lot of nurse practitioners, and I think for them to think that occupational or musculoskeletal assessment is just basically a swollen ankle and leaving, a lot of the history taking short, because I really believe that history taking is 80% of the diagnosis, and then 10% is the physical exam, which really helps provide confirmation to the assessment or the history. And so I think basically having a greater understanding of a framework to practice from with their musculoskeletal assessment helps the provider practitioner do a better job.
So we mentioned history taking. What kind of history taking are we talking about, and why is it so important?
Well, it's important to kind of hear the story of the patient, and if you can do that face to face, and if you can see where their employment is or have a greater understanding of what they do 8 hours a day, I think that helps. But also what they do outside of the workplace is critical, because that gives you another feeling or understanding better of the patient itself. Oftentimes we want to look at some of the other significant health concerns that the patient might have, any other medications they may have, because all of that plays in, and I'm kind of going over it quickly, but there's a lot of components to history, and that's what I talk about in my presentation today, so that people can understand how critical history is. History is 80%, and if you can make 80% of the diagnosis, then hopefully you can hit the bullseye when you get to the physical exam.
So let's talk about, last question, what are some of the techniques used in a good neurological assessment?
Well, I kind of combine the neurological with the musculoskeletal assessment, and I use the first technique is inspection, looking at what you're seeing. What are you seeing right when they walk in the door? And then palpation, where is the pain, palpating the pain, then looking at range of motion, and then from range of motion going through strength testing, and then deep tendon reflexes, which is more the neurological, sensory neurological, and then finally special tests that are specific to the joint or the area that you're assessing, and finally vascular peel pulses or whatever you want to be able to do. But I think that the physical exam is the fun part. It's actually confirming your history. So once you've done your story, heard the story, then you really want to confirm it and back it up with the physical exam. And if it's not backed up by the physical exam, then it kind of makes it like a disconnect for often providers to try to figure out, is this, are the dots connected, and where should we go from here?
Thank you very much.
Thank you.